So it's clear that the adenoma detection rate is really important as a quality parameter, but as already indicated by one of the attendees, everything starts with the basics. So, and the first basic is really a good bowel prep. So I think as a parameter, it's also important to indicate that bowel prep in your colonoscopy report, and you want to have a bowel prep that looks like this, and not like that. So this needs to be standardized. Because if you have a poor bowel preparation, it's really already shown that this impedes the quality of your endoscopy. Not only becomes it more difficult, the time to reach the cecum is significantly increased, but also the detection of polyps of any size and significant lesions is significantly lower in comparison to when the bowel prep is really good and sufficient. And it's clearly stated in the guidelines now, according to 5 meta-analysis, that a split-dose PEG solution has a better cleansing effect, and this is now recommended as such by the ESG guidelines. And important is also to know that the delay between the last dose of bowel prep and the colonoscopy should be minimized to no longer than 4 hours. So you can talk on this for 10 minutes if you want, but I'm not going to do that. A second important thing is obviously the optimal technique. You need to spend time to look. You need to insufflate enough. This study from James East showed that the adenoma detection was improved by better luminal distension, and obviously other issues like sufficient withdrawal time, searching the folds where you really kind of make circling movements while you go back, and sufficient patient sedation, use of carbon dioxide, and antispasmodics can improve your quality and adenoma detection. So this brings us to the top of this quality pyramid. And actually, one of the things that really works to increase your detection is classical chromoendoscopy. There's now a meta-analysis available showing that this increases the number of patients with at least one neoplastic lesion with an odds ratio of 1.67 and with 3 or more neoplastic lesions. And although this has been shown, nobody is doing it. Another indication where this is clearly shown and indicated now is the screening in long-standing ulcerative colitis, where there's an increase of 44% in detection of neoplastic lesions, and especially for flat lesions, there's an increase in detection of 27%. So, but why are we not using it? Well, it's usually perceived as quite time-consuming and cumbersome in terms of spilling on the floor in your clothes. So there's a lot of hope that we can use these digital enhancement techniques. And iScan is one of them, and it consists of 3 different features. The first one is a surface enhancement, where you got a digital enhancement of the edges, and the folds and elevated structures or abnormalities, and the vessels appear more accentuated. And this now corresponds to what we call the iScan 1 feature. Then there is a tone enhancement that digitally alternates discrete parts of the light spectrum, and it will enhance also the vessel and the mucosal structure, and is incorporated in the iScan 2 feature, more particular the C tone enhancement stands for colon at that time. And finally, the contrast enhancement adds some blue color so that the folds and the edges become darker, and this is usually added in the iScan 3 feature. So what can we do with this? There's a nice study from a couple of years ago coming from Arthur Hoffman and Ralph Kieslich, where they randomized 220 patients between standard video resolution endoscopy and high definition with iScan 1. And they used the other iScan features to characterize the lesions. The primary endpoint was adenoma detection rate, and secondary endpoint was the number of flat adenomas and prediction of histology. And these are the results. As you can see, there was a significant difference between standard resolution and high definition with iScan, 38% adenoma detection rate versus 13%. And then also the flat adenomas were increased, as well as the number of neoplastic lesions. There were more carcinomas detected, more adenomas. And in this very first study, it looked very promising that with this iScan technique, adding some tone enhancement on top of that surface enhancement can enable you to predict whether you're dealing with a neoplastic lesion or not. We performed a study in HMPCC, which has now been submitted and finalized, where we had a back-to-back protocol using iScan 2 features or high-definition white light. And you can see here that in the first group, where we used white light first, followed by iScan, the miss rate for the adenomas was 62%. And in contrast, in the second group, where we used iScan first, the miss rate went down to 12%, and this was statistically significant. So apparently, there is is something in this high definition signal that enables you to detect more lesions in a standard population. And according to this study, I think the iScan2 feature also adds in this particular setting of HNPCC, where we're looking for very small lesions in particular. On the other hand, the NBI meta-analysis doesn't show an increased detection as such, so that's not so really encouraging. And it's also not the case for flat adenomas when we pull all the NBI studies together. However, if you go back to the early studies with NBI, what really jumps into the eye right away is the high adenoma detection rate, and for instance, in this study from Douglas Rex, which is really way up to 60%. And the authors speculated that perhaps this is due to the better image resolution. And I think there's a very nice message also in this multi-center German trial from a couple of years ago when they started using NBI. They had a trend to better detection in the NBI mode, but actually what they could find was some kind of a training effect. So you can see here in blue the adenoma detection by NBI, which appeared to be higher in the beginning of the study in comparison to the white light group. But actually the white light group became as good as the NBI group. So actually by using this NBI technique and probably by applying it and in the screening setting where you are going to look differently at a colon, you will be able to detect more lesions. What about cap-assisted colonoscopy? This first meta-analysis showed some slight increase in the adenoma detection rate when used caps. However, two major studies were not included in this meta-analysis, and they were purely randomized controlled trials, so not back-to-back studies. And it showed that it shortens and facilitates the introduction with less discomfort for the patient, but it did not improve the adenoma detection rate. And now we have a new meta-analysis available, a very recent one, showing actually no significant improvement in any polyp detection. And as for the adenoma detection, there's only one study that is positive for an increased adenoma detection, and the pooled data don't show a significant improvement. So now we come back to the GI system. Professor Santo will add more onto that, but just briefly, it's a system that consists of a compliant balloon that can be inflated at the tip of the endoscope, and that helps to straighten out the colon folds. And actually, I've been using it now for a couple of weeks, and what it does, it slows you down when you try to pull back because there is some resistance. So I think this is one of the mechanisms why it may help also to detect more polyps, because it stabilizes you in the colon and you don't have these so-called skipped areas in between. And I come back to another study from last year at DDW, where they enrolled 106 out of 126 patients in two groups, a white light endoscopy group first, followed by GI, and the other way around. And you can see here that in the first group, 21 adenomas and 30 polyps were detected, and GI detected an additional 30 polyps and 17 adenomas. The other way around, there were only 3 additional polyps with white light endoscopy and 3 adenomas. If we summarize the data, you can see that the adenoma detection rate was significantly higher in this study for the GI system, as well as was the polyp detection rate. And you can see that even importantly, on a patient level, there were 8 additional patients with polyps detected and 3 with adenomas. And the adenoma miss rate calculated was 7.5% for the first group and 45% for the second group with white light endoscopy first. So this from detection, you can increase your adenoma detection rate, but I think the characterization and delineation of lesions is also very important. We know this can be done with chromendoscopy, and I think that the study from Mainz assessing the additional value of iScan already indicated that we can make a distinction between neoplastic and non-neoplastic lesions. I think this is important. First of all, the optical diagnosis may be cost-saving, and this has been shown, for instance, for the NICE classification, where they applied a system to discriminate between hyperplastic and neoplastic lesions. And this is done after a short training session. You can really reach high diagnostic accuracy that actually meets the PIVI guidelines. And they wonder if you can use this for a discard strategy, where you either just take out the polyp if it's an adenoma and you throw it away for diminutive polyps less than 6 millimeters, or where you don't even take out the polyp if it's a hyperplastic one. This still needs to be confirmed in a general secondary care setting, but it looks very promising and can save a lot of money that now goes to the pathologist. This has also been assessed in this study, in the FIND study from Pradeep Bhandari's group, where they compared white light with FICE and chromendoscopy with indigo carmine. And you can see that the accuracy is higher for chromendoscopy or virtual chromendoscopy. And they calculated that the rescope interval could be set correctly using one of these systems in 97 or 99% of the cases, according to which guideline you were using, either the BSG or the ASG guidelines. And this would render a saving of almost 800,000 euros per year only in the UK. So why is the characterization important also? Well, it determines whether you need to biopsy or not, but I think even more important, when you see a large lesion, do you send this to the surgery or not? We now are faced with a lot of polyps that are referred for a second opinion, that you can tell immediately, if you're experienced at characterizing the lesion, that it's not amenable even for endoscopic surgery. So you may overestimate the lesions or underestimate the lesions, so you get these unnecessary referrals. The other way around, if you overestimate the lesions, you may want to send a lesion to the surgeon that could have been treated endoscopically. And this has been nicely shown by the Australians, where if you have a granular type 2A lesion like here, which is the most prevalent one, this has a low risk of submucosal invasion. However, the non-granular type of lesions, they are the nasty ones, and you need to be aware that there is a higher risk of submucosal invasion here. And if you add the pattern recognition or the pit pattern characterization on top of that, so if you have a completely disrupted pit here, type 5, in conjunction with a type 2C lesion and non-granular type, well, this is a lesion, although it's small, that needs to go to surgeon. So unlike many things in life, size does not really matter when it comes down to assessing polyps. It's more the characterization of the polyps and so on. So perhaps here there may be a role for the new Magnify system. As you can see, the high-definition images can already identify the polyp, and just by switching on the eye scan, you can already delineate the lesion better, and you can have some kind of idea what's going on in terms of pit pattern here. But when you go really close with the zoom, you nicely can see that this is a type 4 pit pattern, and you can really nicely delineate the lesions here, which enable you to do a full, complete resection and not an incomplete polypectomy. So, Mr. Chairman, ladies and gentlemen, I think it's really important to point out that the basis for increasing your adenoma detection rate and hence your quality of endoscopy really goes down to basic stuff like improving your bowel preparation and using the optimal technique. But I think it's clear that from the literature, although some meta-analyses are negative, that there is an additional value of virtual chromendoscopy, such as eye scan, and perhaps other techniques that can improve it. High-definition endoscopy as such improves the detection of adenomas, and I think this is now the new standard, and there's no longer any rule for standard resolution endoscopy in a screening setting. And perhaps there will be additional benefit for polyp detection for techniques like, for instance, the GI scope, which is simple and readily available. I think iScan is a great tool for polyp characterization. I think it's important also to develop a classification system for a discard strategy for the PKI system, and it can be possibly cost-saving and more efficient for the patient management, hopefully in terms of delineating lesions and selecting the right patients for endoscopic therapy. Thank you very much for your attention.